we will take 3 lectures on diabetes. Today, essential of diabetes. Next will be complications of diabetes. And third will be treatment of diabetes. Then we will go for thyroid. Then we will go for adrenocortical hormones. After each lecture, on the next day, I will give you some MCQ questions. You will get it prepared and submit it back to me. It will be evaluation part. I think it will help you in the long run. So we are starting. What is diabetes? Here almost 40 to 60 students are there. Please raise your hand who are aware of diabetes. How you came to know about diabetes? Either friends or relatives having diabetes, and you have learned in the first year, second year also. What is your concept about diabetes? When we were student, say in 1983, when I attended the first clinical classes in 1982, then diabetes was considered a very simple one of the endocrine diseases. Later it evoluted in a multi-system disease. At that time, there was debate whether to treat diabetes or not to treat. Because what is the harm if someone has high blood sugar? Is there any harm? No. Why should we treat? So this debate was there, and a book was there from Joslyn's Diabetic Institute in America, whether to treat diabetes or not. From that place, in these 40 years, diabetes is a challenging scenario throughout the world. In India, this is considered as the ICU of diabetes, because South Asia, particularly, thank you. India, Pakistan, having the maximum number of diabetes. So those who are interested to continue their professional life in medicine or allied subject, he or she must be knowing diabetes. So diabetes is a metabolic disease with high blood glucose level. Caused by insufficient insulin production or ineffective insulin use. What is insufficient insulin productions? Where it produced? Any idea? Yes? Pancreas. Which part of pancreas? Islet cells of pancreas. And when there is a problem in the production, that is islet cell insufficiency, due to several reasons, maybe a genetic, maybe infective, maybe autoimmune. So in that case, the insulitis is there. The islet cells got damaged. So there is deficient productions of the insulin. And another part is the insulins are there. What is the minimum daily and average daily productions of insulin? Do you know? Any idea? In physiology, have you gone through it? Anyone? No. 24 units. So, insulin is there, but it is ineffective in different reasons. Ineffective, one part is that it is produced sufficiently, but due to some pancreatic disorders, it is not going to the circulation. Or where it acts on the receptors of the cell. Target organ cells, receptors, insulin goes there and insulin promotes glucose to enter into the cell. So, in that where these receptors are damaged or there is insufficiency of or there is insulin resistance, there insulin is there but it is not effective. In that case, again there will be high blood sugar because glucose is not going into the cell, so it is remaining in the blood. So, if we detect blood glucose, it will be high. So, that is again a diabetes. So, this ineffective insulin is called type 2 diabetes. Type 1 and type 2. Other variants are gestational. What is gestational diabetes? Gestational diabetes is the diabetes occurring in first time during the gestation period. There should not be any history of diabetes before that. It will be occurring usually part 1 of the first trimester of the diabetes, and usually gestation is a pro-diabetic itself. Physiologically, it is at that time all the parameters of diabetes are there. So, here it is very stringent to maintain the blood glucose level during the gestational period, because it not only hampers the maternal mother's condition, also there is so many complications of the neonatal period occurs, or in infantile death occurs, macrosomia, macroglossia. There are several complications arises when there is high blood sugar during the pregnancy. So, this gestational diabetes has to be made special precautions during that period. There are other specific types. I mentioned one, there is pancreatic disorders. Others is monogenic. What is monogenic? Now, that is a genetic disorder which leads to diabetes. Now, usually type 1 diabetes occurs in the very younger age group, say 3 to 4 years it manifests, and patients are diagnosed very young due to several infections. They have diabetic ketoacidosis prone by 13 years, and by 17 to 18 years they have repeated infections if it is not being treated with insulin. And type 2 usually occurs in the adult group, adult age group. Now, there are some variations also. This is for short note. One is LADA. What is LADA? LADA is latent autoimmune diabetes category. So, this latent autoimmune diabetes in adulthood, actually it is a autoimmune disorder leading to insulin deficiency, but it is very slowly progressing and it usually detected after the age of 30 years. And these patients ultimately will be requiring insulin in the late stage, whereas in type 1 from the very first they require insulin. And there are another variety, the type 2, that is adult onset diabetes, is occurring in the young. So, those are called MODY. So, maturity onset diabetes of the young. So, there is one side that is type 1 diabetes, which is insulin inefficient, insufficient. There is another variety, that is LADA, which is occurring in the adulthood, and here type 2, where insulin is inefficient, but there is another variety, MODY, which occurs in the young. Types of diabetes: autoimmune destructions of the beta cells leading to insulin deficiency. I have explained. Type 2 is insulin resistance for relative insulin deficiency. Why relative insulin deficiency? That I also explained, that insulin is there, but it is not coming out of the pancreatic cell due to some disorders. Here one important MCQ question: cellular diabetic marker, glucokinase level. What is glucokinase? Have you gone through the cycle in the biochemistry? Glucose to glucose 6-phosphate, that first step is monitored by this glucokinase enzyme. Gestational is first recognized during pregnancy. Now, one important question here: how will know the patient is having diabetes before gestation? A patient, a pregnant lady came to you, has been diagnosed of having blood sugar level, then you don't know, ask her that whether you have diabetes. Oh, no, I don't know. So you have to differentiate between that it is the existing diabetes conditions or it is gestational. Before terming it gestational, how you will do it? Any idea? Good. HbA1c. Why HbA1c? 3 months calculations. Yes. This is a very important thing to differentiate. Another monogenic, I have told you, monogenic there are two types. One is MODY, another is neonatal diabetes. Neonatal diabetes is a special category, monogenic variety. Drug induced. Do you know any idea of which drugs cause diabetes? One drug, please. Glucocorticoids. And disease related. Some disease conditions also causes hyperglycemic states, just such as growth hormone, that is what we call acromegaly, thyrotoxicosis. This sort of hormonal changes also causes high blood sugar levels. What are the symptoms? Polyuria, polydipsia, polyphagia. Fatigue, blurred vision, weight loss, usually in the type 1, and often asymptomatic in type 2. Now, this is very important. When we will term a person diabetic, keep it in mind clearly. The PPT will be you and you go through the books. This has been changed from the beginning. This 2-hour OGTT more than 200 is or equal to 200 is, if it is causes, then we will term this diabetes. Now, what is OGTT? Any idea? Can you explain how I will do it or you will do it? What directions you will give to the patient? There are another step before that. That is the person will be advised to take free diet for last 3 days, not restricted diet. Then you advise that on the day before 8 hours fasting. Then the person will sit down for 30 minutes, rest. Then he will be first taking the fasting blood sugar. Then he will be given that 75 gram of dry glucose mixed in water. And every 30 minutes blood sugar will be taken. up to 2 hours. So, why in between are the case, this oral glucose tolerance, the pattern we have to see. In the next time we will discuss during treatment, there is the incretin effect. So, whenever we are giving glucose, there is a rise in the blood sugar, and this is controlled coming down by the insulin and incretins. Incretins means GLP-1 agonist in the intestines. So, they will cause the rapid metabolizations of the glucose to bring down the blood sugar level. So, this is a very important OGT. OGTT will be minded. It may come as a how you proceed a patients for OGTT in short note also. And OGTT is a very important parameter to diagnose in gestational diabetes also. Complications, grossly, acute complications, most common diabetic complication is hypoglycemia. Hypoglycemia is more dangerous than hyperglycemia. There are usually 5 types of coma we found in diabetic patients. One side is hypoglycemic coma. Coma means unconsciousness due to hypoglycemia. And there are different types of hyperglycemic coma. One is diabetic ketotic coma. Then another is hyperosmolar coma. Hyperosmolar means when there is a very high blood glucose level. So, it increases the osmolarity of the blood. So, blood got thickened. So, when it is passing through the micro vessels, it gets plaqued. So, that is a very dangerous situation leading to this is the most serious complications. So, whenever there is you are getting a patient with high blood sugar, first advice should be to have adequate hydration. Otherwise, the patient will have some severe complications immediately. What is the high level? That is more than 600 blood glucose level. Another is diabetic ketoacidosis. If we adequately treat, this is diabetic ketoacidosis, very commonly found in type 1. In type 2 also, when there is a very tissue is deficient of glucose, what happens? It remains in the blood. So, there is very high blood sugar level, but tissue is having deprived of the energy source. So, they are converting into fatty acid oxidation, leading to some acetoacetate, hydroxybutyrate, ketone bodies generation started. And that when you detect ketone bodies and patient is severely dehydrated due to high blood sugar, there is osmosis, dehydrations, and patient usually it occurs with the infection. So, this diabetic ketoacidotic patients are challenged in the ICU. It causes severe electrolyte disbalance. So, to manage it, you have to follow step-by-step procedure. So, we will come this particularly ketoacidosis management in our management class of treatment class. What are the chronic complications? Retinopathy, nephropathy, neuropathy, all are microvascular complications. And there are macrovascular complications, heart, stroke, PVD. The PVD is peripheral vascular disease. Peripheral vascular disease, there will be peripheral arthritis, and then we will get typical gangrenous ulcers in the leg, which will ultimately produce to a severe complications. Foot ulcers and infections, and some other dermatological manifestations also. management overview. Just first we start with exercise, lifestyle modification. What kind of exercise, what diet, that has to be clearly mentioned to the patient. Exercise means we should have minimum 30 minutes of exercise per day, 5 days a week. And diet based on the calorie. Most important is the quantity, not quality. So we should tell them that you can have one sweet, but this sweet is having 200 calorie, and 200 calorie means 4 chapatis. So you are, what is very important for you, if you want to have your satiety center relaxed, you have 4 chapatis, because with one sweet you will not having your satiety centers satisfied. So you will be having some, if you are taking sweets, you are not having your sufficient feeling that we are having food, so you will go on further eating. So if you maintain your calorie with the food you have in your surroundings, is the best way. I like to mention, I am going offbeat, one Pakistan based doctor, I just forgot to dump some Mumim. He has given a study report which is very important actually. That during the British rule, there are almost 200 famine, with which crores of Indians died due to fasting. That means with hunger. Particularly in 1943, Great Bengal famine, 6 crore persons was died in that famine. So what was the population density of India at that time? 30 crores. So a huge amount of persons died within this 200 period due to some political or socio-political situations, this famine. So who died at that time? Who are fast metabolizers. We know there are 2 types of metabolizers. One is fast metabolizers and one are slow metabolizers due to some genetic predispositions. Slow metabolizers can metabolize the food very slowly. So they require very less amount of food. They can survive the hunger period for more period of time. But those who are fast metabolizer, you learn it in the metabolisms of the drugs. You will see that some those who are fast metabolizer, INH for TB medicines causes more damage, more complications. So these fast metabolizers persons are died mostly at that time famine. So those who have survived, they are mostly slow metabolizers. So we are the descendant of the slow metabolizers. Now what we are doing? Being a slow metabolizer, we are consuming fast foods. So that reason is giving us fatty liver, central obesity, adiposity. So this way we have to think about, when I am telling about diet, that fast food we have to avoid. We have to explain very well, counsel everybody very well to reduce the consumptions of the fast food. Am I clear? Medications will come on. The type 1, only one option is there, insulin. But in LADA, which I have discussed before, which is also insulin deficient, but in those patients, we start with usually with OHA, oral hypoglycemic agents. In the last part, they require insulin. Type 2, first line always is metformin. Next, other oral agents, SGLT2 inhibitors, DP4 inhibitors, GLP1 agonist, and insulin if needed. During the period, we have to monitor blood glucose, HbA1c, regular foot and eye exams. So, what is the key takeaways? Diabetes is a diverse group of disease with high blood sugar. Early diagnosis, comprehensive management prevent complications, patient educations and self-monitoring are very important. My condition is that I am coming from South Chobbish Pargana, crossing 5 districts to come to Birbhum. So, I start very early, still anywhere, any places, some 10-15 minutes delay is there. So, if there is class can be arranged at 10, it is easier for me. You please check. Who called me? Who is the, you just see Tuesday, either myself or Dr. Sujan Sarkar will be taking. So, we will adjust, you just coordinate with us. Huh? And number 2, that after diabetes, and Dr. Sujan Sarkar will be giving lectures on the nephrology. So, we will ultimately, after completion of diabetes and nephrology, we will discuss one important aspect of the complications of diabetes separately, that is CRM. CRM is cardio, renal, metabolic part, because future is based on this, and we know also non-communicable disease, NCD. Any idea what is NCD? If we see, as a persons, I am assuming you are all in the medicine group. You are facing a patient. The patient either coming with some infectious disease problem, that is either communicable or non-communicable infections, and otherwise is connective tissue disorders, endocrinal disorders and metabolic disorders. So, this part is non-communicable diseases. So, if special attention is given to the infectious group, there is a subset of this. Now, there is courses in infectious disease. Previously, it was not there. Now, there is a DM course in the infectious disease also. But non-communicable disease is the disease of the masses. Now, today, we have seen that those genetic evaluations shows that 20% of the diabetic patients require ultimate renal support in the long run. That means either renal transplantation or dialysis. So, you see, it is assumed that by 2030, when you people will start practicing, there will be 50 to 60 million people having diabetes. So, 20% of that, if require support of either dialysis or renal transplantations, and more often these patients will be something around 50 to 60 years of age, what will be the economic conditions of our country? Whether we will have that sufficient infrastructure to support this huge amount of patients during that period, or a huge amount of people will be off from generating resources for their family, for the society, for the country, where will be our economic condition? So, utmost importance has to be given for prevention of diabetes. So here I like to know from you, I have mentioned that in the slide, that diabetic categorizations, diagnosis of diabetes based on which part. Now what is pre-diabetes? 126 is the cutoff for fasting blood glucose. From 110 to 126 is pre-diabetic. And if there is a 1 or 2 incidence of random blood glucose time, irrespective of the food intake, is more than or equal to 200, is diabetic. But before that, from 140 to 200 is pre-diabetic. So if we found some pre-diabetic, how we will find? We have to target health checkup camps and college blood glucose test in the screening in the colleges to find out the potential pre-diabetic patients and to educate them individually. So this is a huge task. So there are several NCD clinics already, central government has started different places. So you also spread message to your peers, to your friends, to your families to check blood sugar level so that we can early treat and maintain the blood glucose level.